seats. Our final session today is on a very important topic, abortion and contraception for patients with blood disorders. Maureen Baldwin couldn't be with us, and we will see her virtually. And then Kristina Haley will speak, and then Janice Bacon, one of our board members, will come and with Kristina for the Q&A. So we'll start with Maureen. She's Associate Professor of Obstetrics and Gynecology at OHSU in Portland, where she completed her medical training, including a master's degree in public health and a fellowship in complex family planning. Dr. Baldwin has a practice-focused designation in pediatric and adolescent gynecology and is co-director of an interdisciplinary hematology and gynecology adolescent clinic called Spots, Dots, and Clots, which treats teens with heavy menstrual bleeding and clotting disorders. And a shout out to OHSU that had one of the first clinics that as part of the FWGBD supported structure. So we will listen to Maureen.
Hi, everyone. I'm so pleased to speak to you today about practical issues of hemostasis from my perspective as a complex family planning specialist. After the past year, this is a difficult topic, but it deserves our attention more than ever. I'm going to bring us back to our large body of research about obstetric safety risks and hemostasis relating to early pregnancy uterine evacuation, and I'll also touch on policy implications for access to contraceptives. Neither of us have conflicts of interest. In this session, we're going to cover the best practices concerning abortion and contraception procedures for women and girls with blood disorders, including procedural bleeding risks, typical measures, and prophylaxis, and impact on policy on bleeding risks and management, as well as best practices to prepare your patient. Induced abortion versus management of early pregnancy loss are the same procedures with the same risks, not including cases with forced delays in care due to policy. First, a bit about terminology. The medical definition of induced abortion is the intentional interruption of a viable pregnancy by medication or procedure. Viability defined usually as expected potential of postnatal survival. The medical and legal definition of pregnancy being the conclusion of implantation. But regardless of initial status of the pregnancy or whether induced or spontaneous, the entire process of abortion is complete evacuation of the uterus. An abortion is incomplete if there's blood clot or placental fragments remaining. Incomplete abortion can occur in the course of spontaneous and medication abortion, not infrequently, but more rarely after procedural uterine evacuation. Incomplete abortion is a significant contributor to abortion morbidity, primarily due to bleeding, and thus management of this phase is considered an essential component of obstetric care by the World Health Organization. There's a spectrum of abortion procedures, including medication only and procedural, spanning from using a small suction catheter to gravid hysterectomy. While the vast majority are extremely low risk, procedures like abdominal hysterotomy and gravid hysterectomy can be much more morbid, performed for things like cervical cancer and morbidly adherent placenta. But they may also be the only options in places without providers trained in second trimester evacuation. Guidelines for safe abortion are laid out by the World Health Organization, including guidance for management of post-abortion care, including people presenting to the health system after illegal or unsafe abortion. Of note, WHO distinguishes self-managed abortion from unsafe abortion, including self-assessment of eligibility, administration of medications outside a health facility, and self-assessment of the success of the abortion. Additionally, this report in blue, The Safety and Quality of Abortion Care in the U.S., is a comprehensive report by the National Academies of Sciences, Engineering, and Medicine, published in 2018. Not surprisingly, their main finding was that safety and quality vary by U.S. region and healthcare system. Abortion in the U.S. has been very safe over the past few decades, including for people with bleeding disorders. Major complications occur in about 2 in 1,000 abortions, with overall complication rates of about 2%, mostly minor. The alternative to abortion, of course, is childbirth, which carries a 29% risk of complication. Abortion is safer than other common procedures such as wisdom tooth extraction and tonsillectomy, yet the public perception is still that abortion is very risky. U.S. maternal mortality rates associated with abortion are extremely low. In the inset graph are total U.S. abortions per year from 1973 through 2020. You can see that the rate per year peaked around 1.5 million in the 1980s and has been steadily declining until the COVID pandemic. In the bigger graph is abortion-associated maternal mortality through 2018, which is from legal abortion in purple and illegal in orange. In 1973, the year that abortion was legalized nationally, 48 people died from abortion. A combination of increased access to safe services, skilled providers, and introduction of ultrasound improved abortion safety. The biggest contributor to abortion safety is an environment of safety and quality. And increased access to earlier abortion is probably the most important component. One of the ways we see the contribution of access to earlier abortion is access to early medication abortion. Since availability in 2000, the proportion of U.S. abortions has grown to a majority by 2020 of 53%. Medication abortion is the self-administered two-step process of mifepristone and misoprostol taken at home. While ideally the patient has obtained these medications legally and under the care of a provider, as I mentioned, the World Health Organization has determined that patients can safely determine their own eligibility, can take these medications appropriately, and can determine whether they were effective even when obtained outside the healthcare system. However, bleeding amount from medication abortion can be variable and is generally considered not an option for people with bleeding disorders. During the approximately 90 minutes of contractions to pass the gestational sac, it's normal to have gushing and passing large clots. The amount of bleeding correlates to the size of the pregnancy. In this study from the UK in the late 1980s, participants collected their pads for a calculation of measured blood loss over the entire process. This data demonstrating more variability in bleeding amount at greater than 56 days gestation led to the recommendation to limit the procedure to 9 weeks initially. The current dosing regimen is safe and effective up through 11 weeks gestation and FDA approved now through 10 weeks. Above 9 weeks, serial doses of misoprostol are administered to decrease time to complete expulsion. But overall, the median measured blood loss is around 75 milliliters. After the typical crescendo-decrescendo bleeding with expulsion from medication abortion, heavier bleeding usually lasts about 2 days, and lighter bleeding continues for up to 1 to 2 weeks in patients without bleeding disorders. Switching gears to procedural abortion, prior to 15 weeks gestation, this procedure is completed entirely with suction, either with a handheld syringe or an electric vacuum suction machine. The tissue is examined to confirm complete evacuation. Sometimes ultrasound is used as well. The total blood loss is usually described as 25 to 50 milliliters, but studies of measured losses have found a median of 75 milliliters, very similar to medication abortion. Greater than 100 milliliters is considered a hemorrhage. Most hemorrhage is associated with retained products of conception, so repeat suction is performed, which is usually effective immediately. Other causes, though, are uterine atony and cervical laceration. Very rarely, someone has much more bleeding than expected, and in nearly all of these circumstances, intrauterine balloon tamponade for a few hours is effective as the next step. We really have no data on procedural bleeding amount for aspiration abortion for those with bleeding disorders, but we do have this limited data in the setting of anticoagulation demonstrating that bleeding is probably more than double in the non-anticoagulated, but compared to non-anticoagulated, but still under the threshold that's considered hemorrhage. Pretty small numbers though. Uterine evacuation in the second trimester sized uterus requires instrumentation with forceps to disarticulate or decompress the fetus, and then is followed by uterine aspiration. So preparation of the cervix with slow absorbing natural or synthetic sterile osmotic dilators changes the stromal composition of the cervix with the goal of a 2 to 3 centimeter dilated cervix. And you can see this process in the dilators on the left here. Frequently, my team is consulted to urgently evacuate a uterus, and we're really unable to do so quickly without this cervical ripening, a very important part of the procedure. And there's a large body of research, including a Cochrane review, supporting regimens for preparation for the different procedural techniques that are necessary to evacuate the uterus based on size. Inadequate cervical preparation is a significant risk factor for bleeding with second trimester procedures. So I'll just note here that above 18 weeks or so, we offer both labor induction and procedural evacuation to the patient, but most patients prefer to have a sedated procedure. Bleeding amount is similar for both induction and D&E, but retained placenta can occur in up to about 10% of labor inductions in the second trimester, requiring a D&C. Additionally, time to fetal expulsion is much longer with the labor process, so D&E is preferred for patients with medical conditions where close monitoring or fastest resolution of the procedure is needed. We offer labor induction following induced fetal demise unless palliative birth is preferred by the patient, such as in expected lethal conditions, and then we offer neonatal palliative care. Median blood loss from D&E is considered around 150 milliliters, but researchers at UCSF compared estimated to measured blood loss and found consistent underestimation. To do this, they suctioned amniotic fluid at the start of the case and then weighed blood. They then created a list of estimates of normal blood loss beginning at 150 milliliters at 16 weeks gestation and increasing by 50 milliliters until 23 weeks and then by 100 milliliters to give us a nomogram of expected blood loss. I mentioned previously the bleeding contraindications for medication abortion. For procedural abortion, there is risk assessment mainly based on procedure location. Generally, this screening is performed by a patient intake form at most outpatient clinics. It's usually self-completed as well, so patients could leave off their risk factors. For more complex patients for whom we're deciding about an outpatient surgery center versus inpatient operating room experience, we're mainly concerned with risk for needing transfusion, such as pre-existing severe anemia or abnormal placentation. Anticoagulation is really not considered to be a contraindication to outpatient procedure for most patients, but it really depends on the setting and the provider's comfort level. The Society of Family Planning clinical recommendations outline management of anticoagulation among individuals with thrombosis risk, which is very similar to peripartum management, though we would generally continue anticoagulation if there are not additional bleeding risks. And this guidance includes a lot of good pearls for management of bleeding disorder as well. Sometimes being in a hospital operating room can increase bleeding risk, though. It's not necessarily the safer place to be, either due to an inexperienced OR support team or even the type of anesthetic. Volatile anesthetics are associated with increased blood loss due to atony compared to propofol, which is preferred. The largest contributing study here, I'm proud to say, was done at my own institution, where we now use deep sedation with propofol for most procedures. At this point, I'd like to point out that there really is no data to guide management of people with bleeding disorders undergoing abortion. One review about provider attitudes about reproductive health did not discuss procedural concerns and mainly focused on decision-making in the context of a prenatal diagnosis of hemophilia. So really, this is kind of an open area that needs more publications. In clinical practice and in the SFP clinical recommendations, we use the following considerations: that procedural abortion is preferred for shorter monitored duration, but inpatient medication management would be acceptable as long as monitoring can be obtained. The location is individualized, considering higher level of care depending on bleeding risk and mainly on available support services. That we consider avoiding paracervical injections to avoid a hematoma in the paracervical space, and for this reason, usually a higher level of anesthesia would be needed. We do also consider vasopressin regional block if we're concerned about oozing. Of course, that's also an injection, usually with 5 units of vasopressin. We would recommend ultrasound guidance for increased safety and adequate cervical preparation and visualization, particularly for more challenging cases with obesity or prior cesarean, and then consider prophylactic antifibrinolytics and uterotonics. Post-pregnancy pain management, I just would mention in patients with bleeding disorder is just, since NSAIDs are the mainstay of treatment for pain post-abortion, we would recommend proactively recommending COX-2 selective NSAIDs like celecoxib if the patient can't take ibuprofen. When things don't go smoothly and there's ongoing hemorrhage with a case, treatment is really still first surgical management and then to correct the coagulopathy. Our first step is to ensure uterine evacuation and that it's empty. And so typically if there's extra bleeding, even if we can't see retained tissue, we'll repeat suction under ultrasound guidance. If that's effective, we might observe again for several minutes and then sometimes repeat if the uterine cavity fills again while we're maybe also administering uterotonics or TXA. We might use a catheter test to determine the location of bleeding by placing a catheter disconnected from suction to the fundus and then withdrawing slowly until bleeding is noted. This is particularly helpful in determining if there's an internal cervical laceration. We drain the bladder to aid tamponade, massage the uterus, and then place a balloon or packing for tamponade, similar to third trimester. Of course, most uterine balloons are developed for postpartum hemorrhage and are just too large to fit even a second trimester uterine cavity. The 30 cc Foley balloon has become the mainstay in this setting and is filled with saline just until resistance, which often is not even more than 15 milliliters. Vaginal packing is also placed, as well as a urinary catheter. And the drainage tip allows monitoring and drainage of any active bleeding above the balloon. Balloons are usually kept in until bleeding stops or up to 24 hours, but there are not studies of the shortest effective duration, especially in this setting. On several occasions, I've seen them be effective between the time of transfer from an outside clinic to the emergency department in less than even a couple of hours. This is a nice graphic of balloon capacity from a study where these balloons were filled ex vivo until they burst. And you can see the vast difference in sizes. Several of these were developed for esophageal bleeding. This article nicely lays out the pressure differentials of the different materials as well. And on the far left is the low resource condom catheter with a latex condom sutured around a red rubber catheter. And then you can see the latex Foley, which is a recommended 35 mil maximum and ruptures at 120 milliliters, and then followed by the silicone Foley, which has a 10 mil maximum recommendation with a rupture at 50 milliliters. And then Bakri balloon, which is the second to last on to the right, where it says 500 milliliters is the fill amount with rupture at 2750. And then uterine packing is not used as frequently now as in the past, but there is some movement on this front, especially in low resource settings. This is X gauze, a trauma gauze with little pellets like those tiny washcloths from the dollar store. And once they're wet, they expand rapidly. This gauze is used for gunshot wounds and on the battlefield. Some of my colleagues are involved with early studies by obstetrics evaluating a new applicator for use postpartum, which is moving toward regulatory clearance in Asia, in India. And a smaller packing is in development as well. There is no hemostatic agent on these pellets. They simply just expand rapidly. Other suction application devices have been attempted in smaller uteruses off-label, but generally don't fit and are expelled, like the Jada, which is for over 34 weeks gestation. I know this audience is full of researchers, so I'll just highlight some of areas in this in the area of abortion care that I think we'll hear about more in the next few years. So the first is management of uterine atony in the first and second trimester. It's easy to just give the same uterotonics we use for a term patient, pregnant uterus, but a second trimester uterus is not just smaller. We need to understand more about the gestational cutoffs for responsiveness. One of my colleagues at OHSU, Jessica Reed, was able to obtain myometrial biopsies immediately post D&E using a transcervical needle biopsy, and is assessing oxytocin receptor regulation based on gestation, and I'm sure there's other work in this area as well. Bleeding risk assessment, improved imaging modalities for detecting morbidly adherent placenta in the second trimester and first trimester would be really valuable. The third is that bleeding management with abortion is treatment-based, but we need to know more about who would benefit from prophylaxis, such as with prostaglandins or antifibrinolytics. One of our outpatient abortion clinics is now administering prophylactic TXA to all patients. We need to understand the benefits and considerations of this strategy. Fourth is that for bleeding treatment, understanding the needed duration of tamponade, for example, could reduce overnight observation. And fifth, finally, we need more studies measuring bleeding risk among those with bleeding disorders and measurement of relative morbidities due to impaired access to first and second trimester uterine evacuation. I'm going to spend just a really short time talking about how restrictive state policies on abortion might impact contraceptive access. Just going back to the definitions of abortion and pregnancy, both the medical and legal definitions of pregnancy are that it starts after implantation, and that abortion is the interruption of pregnancy. By those definitions, interruption of a fertilized egg is not abortion. But these multiple personhood amendments, which have been passed in multiple states, apply a different status to the pre-implantation conceptus and imply that impeding successful implantation is abortion. This implication has a lot of people confused about contraceptives and confused whether contraceptives impair implantation, including postcoital contraceptives. In particular, any contraceptive that results in impacts on the secretory endometrium is called out as potentially impacting implantation, which gets really confusing. And we'll just highlight the mechanism of action of the levonorgestrel IUD in particular. It's a key example of a medication with a multifactorial impact. Its primary mechanism is as a barrier with cervical mucus, which you can see in the bottom panel, is impenetrable to sperm. In addition to this barrier activity within the uterus, it acts as a spermicide, rendering sperm non-viable if they were to pass through. And then impairment of ovulation is another factor, which is not necessarily employed as the main strategy as contraceptive, but is very contraceptive. And then finally, we know that there are changes to the endometrium with the levonorgestrel IUD, but whether those are actually acting in the contraceptive pathway and whether they actually would impair a potential conceptus that really would be really difficult to create given the barrier to sperm is really far-fetched and is not a likely mechanism. And so I think applying these concerns about impairment of implantation to the IUD for one are really fraught, especially when we're using the IUD only in people who are not, who we know to be not pregnant currently or not at risk for pregnancy recently. So I think we are going to see the restriction of the IUD in states where personhood amendments are enacted simply due to inability to understand the mechanism and to apply that science to the policy. The legal landscape of obstetric care has changed quickly this year, and it can be difficult to know whether or not something is legal. The best way to understand the law really is to read it, to read the policy language, and then consult with your hospital attorney or the ACLU. The Guttmacher Institute is a research think tank for global and U.S. reproductive health, has a frequently updated website with state data, including this infographic. Another interesting site to know about is the Abortion Access Dashboard, which demonstrates the travel patterns that changed over this past year with state restrictions. The blue dots are facilities providing abortion with travel from restricted areas in pink and from legal areas in green, demonstrating that restrictions result in redistribution of services, not reduction, often applied with increasing disparities. The big blue dot in the middle is Wichita, Kansas, with 2 facilities serving a current catchment of 2.7 million population. You may be peripherally following that there is a current court case involving the FDA and mifepristone. These New York Times articles and ACLU podcast outline the case well, and there was also a Slate article last week with legal analysis. I'm recording this talk on Tuesday this week, and we expect to hear any day now about a ruling for this case from Texas, which may ban mifepristone based on an unfounded assertion that the FDA did not perform a thorough safety review of the medication. And a countersuit to the FDA by 12 states attorneys general is asking for the FDA prescribing restrictions to be relaxed. So we may very well see this case go to the Supreme Court. Since approval in 2000, access to medication abortion has been significantly restricted by the FDA Risk Evaluation and Mitigation Strategy, the REMS, which limits writing a normal prescription. During the COVID pandemic, FDA regulations prohibiting dispensing from anywhere other than in a hospital or medical clinic were relaxed, allowing mailing of medications and eventually dispensing from certified pharmacies in some states, including my own, where I can now write a prescription and my pharmacy will dispense the medications. But these restrictions have really limited access to this medication and service. It's extremely valuable that hematologists and obstetricians speak up about the impacts of delayed access to care for our patients in the multiple ways they can result in increased bleeding complications. There are fellowship-trained complex family planning specialists nearly at every academic center in the US who can help you navigate a referral for a complex case and can help you connect with knowledgeable legal assistance if needed. Patients can locate nearest abortion services through abortionfinder.org. For those of you in restrictive states, we know it's difficult to have your hands tied to be able to provide optimal patient care. And I'm fortunate to work at an institution in Oregon that prioritizes evidence-based care as depicted on the banner that they ran for several months on their website. And now I'll turn it back over to my colleague, Kristina Haley, to highlight best practices for interdisciplinary care. Thank you for your attention.
For that talk and the beautiful view of sunny Portland. And now it's my pleasure to introduce Kristina Haley. She's the director of the Hemophilia Center at OHSU. She co-directs the Spots, Dots, and Clots Clinic, which we heard about, which is a combined interdisciplinary hematology gynecology clinic for adolescent women with bleeding and clotting disorders. She spends time educating medical students, residents, and fellows, as well as community healthcare providers on all things non-malignant hematology, with an emphasis on the care of women and girls with blood disorders. Kristina.
Great, thank you so much. And I'm really sad Dr. Baldwin couldn't be here. This is really, I told her I was like her emotional support hematologist and I would just stand here. Not that she needed me, but I think this is such an important topic, and for us hematologists in the room, it's a procedure. So right, we do procedure planning all the time. I can't tell you how many wisdom tooth extractions, tonsillectomies I've made a plan for in the last week. And those are all much higher risk procedures than an abortion, as Dr. Baldwin just highlighted, and we do it all the time. And so I think we just need to make sure we elevate this and normalize this as part of our procedure planning. So that's why I'm here today, is just say this is something we need to be aware of and just talk about. It's a procedure. We need to talk about like any other procedure that we plan. So I just have a couple slides, and then gratefully Dr. Bacon will help answer questions. I don't know, I'm also not like an oral surgeon, so I don't know what they do all the time when they pull teeth. I don't know all the things about performing an abortion, but I will help support them. There was this ASH abstract that was at ASH 2022 that I just wanted to call attention to. There was a retrospective cohort study looking at cases of females 10 to 45 with hemophilia A or B, or hemophilia A or B carriers, or von Willebrand's disease who had not yet experienced menopause, and then controls, so females 10 to 45 who also had not experienced menopause. And they compared abortions and other early pregnancy complications between the cases and controls. And so in this table, it has a lot of information, but it'll have the controls in the first column and then the cases in the third column, and compares the different rates of these different procedures. And as I'll go on the next slide, sorry, there was a lot of information in those columns, but this also has emergency contraception and controls and cases. And overall, they found that the prevalence rates of abortions, ectopic pregnancies, and emergency contraceptions were all higher in cases. And there was a trend toward an increased rate of delayed or excessive bleeding following induced or spontaneous abortion or ectopic pregnancy in patients with bleeding disorders. And their summary was that it's critical to have interdisciplinary expert care. But I think it just calls attention to, even in, we don't always keep track of this data, or as Dr. Baldwin highlighted in that 2019 review, that was actually of hemophilia A carriers, that the only topic of abortion that came up was whether or not if the pregnancy was affected by hemophilia, and not whether or not somebody had elected to have an abortion for any other reason. Oh, that's this slide. Sorry, I forgot it was there too. So again, I think in looking through all the papers that I could find, there was really very limited data about people with bleeding disorders having elective termination of their pregnancies. So what do we do as hematologists? I think normalizing our conversations around abortion care. We spend so much time, as a pediatric hematologist, right, I do prenatal consults with moms who are pregnant and say, oh, let's plan for your baby. Well, is that what we're going to do? Is that our actual plan? And we come in with some preconceived notions about what the outcome of that pregnancy is, or what the desired outcome. And we need to have the first conversation, is this a desired pregnancy? What is your next plan? I also think it's really important to understand the procedures and the timing of the risks. So knowing when is the expected bleeding going to happen with a medical abortion, that it's going to be right away, but with a procedure abortion that they're going to evacuate and they're going to see what that blood is, and we know right away. And just having that back and forth conversation, what is the right thing for this patient? It's always like everything about FWGBD, right, is to connect with your colleague in the opposite field to make sure we know what's going to happen, how can we plan for this. I've never, until the post-Dobbs decision, that had as many conversations about abortion care. I live in a state where it's a very accessible medical procedure, and with the post-Dobbs decision, we now have states nearby where abortion access is limited. And so we have patients traveling to Oregon. And so thinking about, if this is somebody with a bleeding disorder who lives in maybe the nearby state of Idaho, and they're going to travel the 8 hours to OHSU for their procedure, what do I need to plan for them in their care? Or if the closest place for them to get their care is at the Planned Parenthood that's just across the border in Oregon, what do we need to think about to make sure that they're safe? Questions have come up in our discussions with the family planning group at OHSU of where do we and how do we use TXA? It's a very accessible medication. we can give it orally. But something I didn't realize was like a lot of clinics that offer abortions in the outpatient setting don't always have IV access. And so then we think about, okay, what's the role of oral TXA? In the trauma literature, there's data about intramuscular TXA. Is that something we can think about? And how do we as hematologists share our knowledge of bleeding treatment with our colleagues to be able to think about this differently? I think the other big thing is that incorporating abortion procedures into our research. Are we collecting that data even in our very just basic surveillance data? I think my experience of planning procedures in patients with bleeding disorders is it's often a data-free zone anyways. Like, oh yeah, you should do this medicine for a couple days and let me know how it goes. Like I text my friends, I'm like, what do you usually do? I think we have an opportunity to make, I think the safer we make abortion care, the more it becomes acceptable of that we just are making this as safe as possible. And so I think it's important just to record this data as able without putting anybody at risk. Oh, so there was one more slide, sorry, that we had a little slide squish in me and Maureen's discussion, but we were just talking a little bit about, you know, an example case of somebody with type 1 von Willebrand's disease, let's say, who their bleeding has primarily been related to heavy menstrual bleeding, and they need a first trimester abortion. And so what would our bleeding treatment be? We can take this as a minor procedure. Let's say their levels are over 40%. So we, according to the 2021 von Willebrand's guidelines, we could give them TXA alone. But I think about in my state, again, some people live 6 to 8 hours away. And so I might not be able to get them access to our university quickly. Most of the hospitals outside of Portland don't carry Humate-P or any other factor. And so I might say, well, you know, you're 7 hours away from me. I'm going to give you Humate-P beforehand because I just need to make this as safe as possible, and we want to make sure that you are okay. So I think it's like location, what are the resources in the community, what is the patient's previous bleeding history, just like any other procedure. And so I think that's really our Dr. Baldwin and my big takeaway is that we have to keep considering and reinforcing that this is a medical procedure, this is medicine that we are practicing, and how can we continue to partner to make this as safe as possible for our patients. So with that, I think we'll pause for some questions.
Okay. And thank you, Janice, for, yes.
Hi, I'm Sarah Hawk from Oklahoma, and we are a particularly restrictive and painfully backward state. Not from there originally, I can say that. And we've had recent situations where, because it is such a restrictive state, that patients have been even more reluctant to tell us if accidents happen, they've gotten pregnant, or if they have a miscarriage. They're afraid to call, they're afraid there are going to be repercussions, such that we've even had a patient get into a medical situation because we didn't know when she went in for emergency care, she didn't tell anyone, and thus care was delayed. And so to make sure that our patients understand they can tell us about anything, we're here to help. If they become pregnant, if they have concerns they're pregnant, if they think they might have had a miscarriage, to call us immediately. You know, there are things we can do just to take care of them, no questions asked.
Thank you.
Yeah, I think that's a really good point that we, you know, as I'm a pediatric hematologist, so I spend a lot of time being like, call us if you fall off the trampoline you weren't supposed to be jumping on, or call us when you are playing football and you weren't supposed to play football. And so we do so much of that, like, please call us, we'd rather know than not know. And so I think the same is true, right? Like, we're here to help, and we're here to help you take care of your body, and this might be one of those situations.
And just following up on some of the things that Maureen said, even if the patient goes to another state or another area for her termination, she may not have had the money or be able to access getting an IUD in or something else. So you can help by making sure that you or one of your colleagues gets her started on contraception as soon as possible.
Yeah, I had a sort of an ancillary question. We read about the lack of training of fellow, residents and fellows in OBGYN in, abortion procedures in many states. Is that sort of taking hold? Is that, I imagine it is, but my information's from the popular press. So.
Yeah, so in South Carolina, we're listed as a very restrictive state, but so far most of the most restrictive bills have been defeated, and so we still have options for termination up through 20 weeks gestation from Planned Parenthood and private clinics in the major metropolitan areas, but it's under constant assault. But mostly the programs are teaching residents about doing surgical procedures in patients with failed pregnancies, and then discussing how some of the differences might be managed. For example, the decreasing rate of human chorionic gonadotropin takes longer in somebody that's discontinuing a pregnancy that had a heartbeat versus one that was already FDIU or blighted ovum. So trying to extrapolate the education and putting it with the procedures that they're already doing is probably the biggest thing that I hear about.
I don't know all the details of this, but following the Dobbs decision, there was a group in Oregon that created a fund to support bringing trainees to OHSU, and we just had our first trainee that came through from a state where abortion restrictions are high, and so they came to our institution to learn procedures and everything, and then that was part of a philanthropic funding.
Hi, Michael Pates from And just to follow up on Nigel's question, it's exactly what we're experiencing in Miami. So right now in Florida, so one of the graduates of the medical school, senior person, had donated, she lives in California now, set up a scholarship in case we need that for our students to go there. Now, I have a family planning division in there, not a fellowship yet, but a division. And about half of the procedures are actually for incomplete abortion, miscarriage management, so not all viable. So they are getting experience on both sides. But I think we're going to be seeing more of these students traveling.
Is there a fear, though, in terms of, I read about a fear in terms of managing pregnancy loss, and as a physician, and will you be at risk and the individual be at risk for procedures that you do to manage that situation?
So there is some fear, but it's because the different options have been turned over to states. There's going to be some locations that are more difficult than others. What we talked about in South Carolina when some of the restrictive measures look like they might get a positive vote is we tried to look at the language that the legislators put in and then looked at the exceptions, trying to word them in the legislator's bill in order to mention, I'm sorry, I'm not saying it too well, but trying to use their wording when we're seeking the exemptions.
Yeah, with all their medical training.
It doesn't, they think they can run everything, but
Yeah.
yes.
Raj?
So, Kristina, I agree with you, but I think we should add a component of education to both medical students, physicians, and patients about the risk of about types of unsafe abortions, because in my very short stint as an OBGYN, when I did about a year or two of training, I saw knitting needles stuck in, or herbal medications, or, you know, things put in the vagina that you think, what the heck is that? And I think if we teach our patients that, you know, these carry the risk of sepsis and this and that, or whatever it is, that should be something we should add to our patient and physician education.
Yeah, I think showing them that we as physicians are a safe haven, and I know that's hard because not all of our colleagues may be a safe haven, but in OBGYN, the majority. I wanted to say one thing about needles, just to divert. When Maureen was talking about injections into the cervix, so one of the things that you can do is inject 10 units of Pitocin into the cervix. You may just want to put it in where you had your tenaculum and then put your ring forceps right back on it. And that way you can utilize an additional uterotonic.
Anyone else? Anything else from our panelists?
I think the FWGBD for letting us talk about this topic, and I'm so glad it can be a normal topic of conversation, and that we can just learn about the nuts and bolts about it like we would anything else. And so I'm just grateful that we're able to have this discussion.
And
Yes.
Yeah, Andy James, Durham, North Carolina. I hope that we can get this out in a paper. I think that what you and Maureen and Janice here have done would make an excellent paper that would be a great resource. And I think that hemophilia would consider it.
I just wanted to add too, I haven't heard a lot of discussion or seen a lot of topics on this, but some of my patients with bleeding disorders, even when they're using an IUD, they tend to have a lot of spotting and breakthrough bleeding, which makes them not very happy with their choice. And certainly I have seen in some of our literature for patients using a progestin or a non-hormonal IUD, the addition of a second method of contraception to control their bleeding or their acne. There's not a lot that you can find on that in the literature, but that is a good thing to think about, because if the girls already have a difficulty clotting, then they're not going to be at much risk.
Yes.
Perfect. Lynn Malik, I'm from the Versity Blood Research Institute. I would completely echo what Kristina says about just the thanks for being able to have an open and informative discussion. And I think, you know, part commentary, but also maybe call to action. And I like what you mentioned in terms of how do we maybe more widely disseminate this. And Dr. Bauman's aware, I had a recent carrier in Milwaukee, Wisconsin, who had called and didn't really want to give information, but she had a early, I think an 8-week pregnancy, and was going to need to travel across the border for a termination. And she's a symptomatic heme carrier. And so I think through this process, what I struggled with was all the stuff of what do I do for her so that she can safely have this as a procedure, and where she won't have bleeding that either lands her in, you know, a reasonably small town in Illinois, or that she comes back and has hemorrhage and might not want to seek care, because I think both of those are real issues. And so one of the things that I recognize is, you know, it's just like when we have patients go to the dentist and they don't say they have hemophilia or that they're a carrier, you know, that provider doesn't necessarily know that there's anything to worry about. And so I had a discussion with the NP. They were really appreciative of the fact of, okay, these are the things that I'm thinking of. We're going to have her pre-treat with intranasal DDAVP. We're having her start Listida. I'm going to have her do intranasal DDAVP the next day. And so I think that's some of the piece of the proactivity. I reached out to Dr. Bauman and Dr. Perez-Botero and said, do you think I'm over-treating her? Do you think I'm under-treating her? You know, this is my kind of N of one story, but I think as I was getting off the phone with the nurse practitioner, said, you know, this would be a great way. I'd be happy to give a talk to your center, because thank you for taking care of my patients that need to come across the border.
Yep. That's great. And also, one good thing about the electronic medical records, you can put your plans for the patient in a MyChart message, and she can pull that up, even if she can't pull up her medical records because the clinic she's going to is not on Epic.
Right, great.
That's a great point. The other thing I was going to say too was something that Dr. Baldwin had said about that a lot of the screening questionnaires are patient completed, and so if somebody might not be as disclosing about a risk that could make somebody say, oh, you can't have this even though you came all this way. And so again, just that, what, like you said, Dr. Kulkarni, like what information can we give ahead of time to tell patients and families, like this is something that could come up, here's what our plan would be, we're here to help, this is just normal, and just how much more can we be proactive.
Yeah, I know about a year or so ago, HemoWare, the NHF magazine, did a piece on abortion, and they asked if I would comment on medical management. And, you know, I really tried to emphasize that this would be almost always considered a minor procedure, and it would be handled as a minor procedure. And this is options that you might have. And I think that emphasizing that is really important. On that positive note, we'll conclude the day. I really want to thank all the speakers and the audience. I think it's been a great afternoon. You can go outside and enjoy some warmth for those who came from places that don't have it. And see you in the morning. I think breakfast starts at 7 and the program starts at 7:30. Anything else? Is that? Oh, evaluations. Please complete your evaluation. Thank you.